So it's my pleasure today to introduce Dr. Lourah Kelly. Dr. Kelly joined the Department of Psychiatry and iSPARC in July of 2023 from the UConn School of Medicine. And part of what we like to do in grand rounds is have faculty who have come in recent times to give a grand round so we can learn about her research. Dr. Kelly completed a T32 postdoctoral fellowship in alcohol treatment research. She is a clinical psychologist by training and received her Ph.D. from Suffolk University in Boston. Her work broadly focuses on co-occurring substance use problems and suicide risk in transition-aged youth and technology-based interventions specifically designed for this age group. She is the principal investigator of a K99R00 Pathway to Independence Award from NIAAA entitled Development and Evaluation of Avatar-Guided Mobile Health Intervention for Emerging Adults with Alcohol Misuse and Suicidality. She's published 29 peer-reviewed manuscripts with 12 as first author, mainly focused on alcohol and other drug use and suicidality among young people and psychosocial interventions to address these problems. She's also now the lead of the Dissemination and Community Engagement Unit of the Center for Accelerating Practices to End Suicide here at UMass Chan. And she's also a co-investigator on two projects funded by NIDA. These projects test a technology-assisted parenting intervention for parents of adolescents in residential substance use treatment and build the field's tools to study recovery support services for emerging adults. Let's give a warm welcome to fairly new faculty member, Dr. Lourah Kelly.
Thanks everyone for being here, both on Zoom and in person. Thanks, Dr. Rothschild, for inviting me to present to you all today. I'm really excited to talk about digital behavioral health interventions for this age group. I'm really passionate about working with this age group, and I feel like they have a definite need for interventions. I don't have any disclosures to report. I'm not discussing any off-label use of medications, and so we'll be talking about some psychosocial interventions that can be delivered using mobile apps. These are all of the different NIH-funded studies that I have going on right now, and mostly we'll be talking about this first one, the K99ROO. It's my Pathway to Independence Award. That's from the National Institute on Alcohol Abuse and Alcoholism. And like Dr. Rothschild mentioned, I'm really on this research trajectory. So after I completed my PhD in clinical psychology, I did a T32 postdoctoral fellowship focused on alcohol use treatments. Then I submitted a K99ROO focused on alcohol interventions for emerging adults with co-occurring suicidality that could be delivered with a digital health intervention. Initially, it wasn't discussed, and then it was funded on the second round. So if anyone here is interested in a research future, just be persistent, keep submitting. I also have an LRP, a Loan Repayment Program Award. Physicians are also eligible for these if they do research, and I'm a first-generation college student, so I really wouldn't be able to have this research trajectory without additional NIH funding support for my student loans. So our learning objectives today are to understand emerging adulthood as a key developmental period with risk for mental health and substance use problems. I'll give you an example of using user-centered design to create a digital health intervention specifically for this age group. And then I'll share some ways that you as clinicians can choose existing digital health interventions for use in your clinical practice. So first, what is emerging adulthood? It's really this unique period of life. It's been described as 18 to 25-year-olds. That's how I define it. That's how it's defined in some national representative surveys. It can go down to about 16 and up to about 28 to 29. But it's really when identity exploration is happening, a lot of transitions. It's marked by instability and change. There's a self-focus, so less focus on serving other people or having children or taking care of parents. It's feeling in between or in progress, so in between adolescence and adulthood, increasing independence from family, physically moving at times out of the family home, pursuing education and training goals and pursuing like a vocation, romantic relationship development, thinking about family planning or actual family planning, and also hopefulness about the future and possibilities. And especially for young adults with mental health or substance use conditions, they can feel very different from their peers if they aren't experiencing that hopefulness about the future. So then what are digital health interventions? I'll mostly be talking about mobile apps today, but digital health interventions are pretty broad. So they can include apps. So these are some cognitive behavioral therapy apps that you can look up on the App Store on your phone right now. Web-based programs. So this is a single session intervention for parents of children with anxiety that was developed by Jessica Schleider, who's at Northwestern University. There are VR or virtual reality interventions that can be done. These are especially helpful for phobias. So for example, it can be pretty hard to do an in vivo exposure if somebody is really having anxiety about planes or flights. So to have VR technology can really be beneficial for patients and providers. There are also wearable devices. So for example, I've seen this used with folks with anxiety disorders that are around like increasing heart rate. So people may feel like, okay, my heart start beating really fast, I'm going to have a panic attack, and that actually worsens those internal experiences and makes a panic attack more likely to happen. So I've seen wearables used with folks with panic disorder where you actually see your heart rate increases and goes up and down throughout the day. And it seems often at times to be actually unrelated to panic attacks. We have video games as well. So I've seen video games used with veterans and like combat activities, but this one is a trauma-focused CBT intervention that's available on the App Store, but I would characterize it as more of a video game. So a monkey guides children through learning about relationships between their thoughts, feelings, and behaviors, and can help alleviate some symptoms of traumatic stress. So why are digital health interventions then indicated for this age group? So why would we offer them to this age group of young adults specifically? So first, it's because emerging adults have the greatest need for mental health interventions. 75% of all mental health conditions present by age 24. We also are seeing that depressive disorders, psychological distress, and suicide risk indicators, so suicidal thoughts, plans, attempts, and mortality, are all increasing more rapidly among adolescents and young adults, and in more recent cohorts. And experiencing a mental health condition for the first time essentially means that young adults don't have established care. They don't have a therapist that they can call up. They might not know how to navigate a treatment system or know what an intake process looks like. We also see that substance use disorders are highest among this age group. So substance use disorders includes both alcohol and drug use disorders, and then they're kind of broken up by all substance use disorders, by alcohol specifically, and then by drug use disorders specifically. Essentially, the green bars are the highest, that's young adults, and they're higher than adolescents and higher than all older age groups as well. We also see this for any mental illness and serious mental illness. So these data that I'm showing you are with the National Survey of Drug Use and Health. It's a national representative survey in the United States. And here, again, the green bars are higher. I know the ones were for any mental illness, they look like they're getting a little bit closer. These are statistically significant. They're representing millions of people. And serious mental illness includes major depressive disorder, bipolar disorder, schizophrenia. So really the odds are kind of stacked against emerging adults. Then we also see these same patterns with major depressive episodes. So even outside of the context of major depressive disorder, and then major depressive episodes with severe impairment are also highest among this age group. I'm going to show two studies that I've published with the National Survey of Drug Use and Health data. These are looking at co-occurring behavioral health problems. So co-occurring alcohol use disorder and suicidality, and co-occurring cannabis use disorder and suicidality. Besides nicotine, these are the most common substances that people in the United States use. I also want to give a special thank you to the second author on the first paper, Richard Liu. He's at Massachusetts General Hospital. I essentially contacted him to do some consultation for data analysis, and he just really encouraged me to run these types of analyses. He said, I know it's a national data set, but they're really no different than analyses that you can do in a clinical trial or otherwise. So just a plug for encouraging postdocs. Okay, so with the results of this first paper that were published in Journal of Affective Disorders, essentially what the STAR means are that young adults have the highest rates of suicidality alone, so looking at passive suicidal ideation or wishes for death first, alcohol use disorder alone, and their co-occurrence. So compared to having neither problem, they have higher rates of all of those things, particularly co-occurring alcohol use disorder and suicidal thoughts compared to all older age groups. This is also true for thoughts of suicide or killing oneself. So young adults have higher rates of co-occurring thoughts of suicide and alcohol use disorder compared to adults 35 and older, and then suicide planning and alcohol use disorder compared to adults 50 and older. The suicide attempt analyses weren't significant. That's with fewer people, so that could be why, or these relationships could be particularly important for alcohol use disorder and thoughts. We saw these same patterns for binge drinking. So again, these don't necessarily have to be problems that rise to the level of a disorder. They're also true for maybe more lower levels of problematic drinking. This survey or this study, though, was with folks who have depressive disorders, depressive symptoms. So in the National Survey of Drug Use in Households, you only get these questions about wishes for death and suicidal thoughts, suicide plans, and attempts in relation to a major depressive episode. So this particular study is only people with any level of depressive symptoms. The cannabis use disorder study findings are with people who have any suicidal thoughts or attempts at all in the past year, so even outside of the context of major depressive episode. We looked at some other demographic groups, so I'm just highlighting the age effects for you. So young adults compared to all older age groups had higher rates of cannabis use disorder alone, suicidal thoughts alone, and their co-occurrence. And we see that for suicidal thoughts, plans, and attempts here. So just more reasons that we should maybe be integrating interventions for emerging adults. So then why would we offer digital health interventions? So why can't emerging adults use the traditional treatments that we offer in our therapy offices? Well, they're not accessing them. Unfortunately, young adults compared to all older age groups are more likely to have not been seen by an outpatient mental health provider, any outpatient provider in our emergency departments or in psychiatric medication appointments. And we also see that most students who die by suicide also don't visit their college counseling center. So even settings that are developmentally appropriate, they're free for students, they're physically close to them, there may be less stigma associated with going to a college counseling center, they're still not accessing those services either. So again, these are just pointing out the larger numbers across the country of young adults not accessing treatment. So this first figure shows what I showed you before, that young adults have higher rates of any mental illness and serious mental illness. So you would think that the treatment services graph would kind of mimic that same shape, would maybe show that young adults are highest and older adults are lower. That's not what we see. So we see that older age groups still have higher rates of treatment services and with both any mental illness and serious mental illness. So it's great that older age groups are getting treatment, but we just still basically need to be doing something different for young adults. So why aren't emerging adults getting treatment? So this is some analyses that I did myself. So these are unpublished data, but essentially what I did was I just took all 18 to 25-year-olds, and then there are questions that they receive if they have an indicated mental health treatment need, but actually didn't receive any services in the past year. The big things to note here are that the cost is prohibitive. It's difficult for young adults to afford treatment. They fear being involuntarily committed. They don't know where to go. They're having difficulty navigating these treatment systems. And they have some perceptions of treatment, maybe that need addressing. So they don't think treatment was needed. They think they can handle their problems on their own. They don't think treatment will help, and they don't have the time. So I'll come back to this, but even people with an indicated need, about 30% of young adults think that they can handle their problems more independently. They don't need formal treatment. So out of all 18 to 25-year-olds, 18.5% of them have an indicated mental health treatment need, but did not receive any treatment at all within the past year. So what about substance use? Emerging adults also are not accessing substance use treatments. So again, the left-handed graph is still showing you that young adults have the highest rates of these problems, but then you don't see those similar patterns with receipt of services. So these are receipt of any substance use treatment services on the top. Only 4% of young adults who have an indicated treatment need are receiving any substance use treatment. And then if you look at specialty treatment, so that's things like substance use residential services, detox services, inpatient substance use services, those are even a little bit lower and are actually higher for young adults, or sorry, higher for older adults compared to receiving any type of treatment at all. So unfortunately, young adults are not receiving specialty treatment, especially they're receiving more care in generalized settings. And by and large, they're not receiving substance use treatment services. So then why? So again, this is back to the unpublished data that I looked at with just 18 and 25-year-olds who report not receiving treatment. It's mostly because the cost, then there's not parity with substance use treatment services, so their insurance won't necessarily cover all of it. They fear it'll negatively affect their job. They don't think treatment was needed. They think that they can handle their problems on their own. They don't think it'll help, and they don't have the time. But most importantly, 45% of them don't want to stop using. And that's kind of a misperception maybe of substance use treatment services. People don't necessarily have to abstain to participate in substance use treatment. They certainly don't for alcohol use treatment, but they feel like they're not ready to stop using. So that's what's keeping them from seeking services. So out of all 18 to 25-year-olds, about 24% of them have an indicated substance use treatment need, but didn't receive any specialty treatment at all in the past year. And it's about 15% for alcohol and for other drugs. Those don't add up to 24 because somebody could have either one of those problems or both. So this is millions of people who need an intervention but aren't receiving any services, and they have a lot of barriers to care. So essentially, if you have a young adult that's in your office and you're doing any type of mental health or substance use treatment, they've really combated a lot of barriers to get there. And if you have more than one session for somebody that is there for substance use treatment, you're doing an amazing job, because the mode, so the most common number of sessions that a young adult attends is one. So some other considerations that we have to keep in mind for young adults. Young adults' brains are still developing. So their more advanced cognitive functions are still coming online. That makes things like scheduling doctor's appointment or navigating a complex system are more difficult for them. They have increased autonomy from parents and caregivers. We know, though, that family-based interventions are really helpful for mental health and substance use conditions. So it just makes like one other barrier for them in terms of getting the best care possible. More independent living and having roommates, again, just like that separation from their parents and maybe navigating insurance systems for the first time if they have insurance. Feeling more in between childhood and adulthood can impact treatment, because many substance use treatment programs are really designed for older adults, and many are attended by people who are, say, 40 to 60 years old. So young adults can just feel like that's a barrier and they're separate or different from people who are also participating in treatment. They also have more non-abstinence-based goals, which can sometimes be in conflict with clinics, and they have fewer abstinent peers, meaning that if they do want to be abstinent and have a weekend where they're not engaging in drinking or substance use, it's just harder for them to find peers to do that with, and harder maybe to get that acceptance. So these are all normative processes, but can make long-term treatment engagement very challenging for this age group. So now I'm going to show you an example of using user-centered design to create a digital health intervention for this age group, really in part to combat all of those barriers we talked about. So what is user-centered design? This is borrowed from computer systems and technology research, but it's basically approaching the user to do what makes sense for them. So many interventions are designed by researchers or by clinicians, not necessarily by the people that are like the consumers of that intervention. It means that we have interventions that nobody asked for. So with user-centered design, you're really designing an intervention that addresses a need that already is apparent in that particular group. It also is an iterative process. So rather than consulting with people at the very beginning or the very end of something, you consult with them and collaborate with them throughout the process to make sure that if there are like user issues or glitches or changes that should be made, we make those as they come up. These were all the barriers that we talked about. I'm going to cover them and just really tell you that digital health interventions can overcome those barriers to engagement and care by offering support when and where young adults need it at a low cost, low time commitment, and without judgment. We know that about 50% of young adults check their phones multiple times an hour, and 1 in 5 people use an app on their phone for some type of health intervention. We also know that apps tend to be used for a short amount of time and then be not used anymore. So there are some things that we have to do to still make sure that digital health interventions are user-friendly and that they're acceptable to people. I know that we talked about co-occurring alcohol use problems and suicide risk. This intervention is designed for co-occurring alcohol use problems and suicide risk. And many clinicians, rightly so, many people can be wary about having self-guided or digital health suicide interventions. So do we even see that those work? So this is some data from a meta-analysis that essentially says that over 4,000 people were offered digital health interventions for suicide risk in 16 studies, and there was a small effect on suicidal ideation, but only if the intervention is specifically talking about and teaching skills for suicidal thoughts. So interventions that are indirect, maybe, so that are for depression or anxiety, aren't necessarily going to help patients with suicidal thoughts. So these digital health interventions can be effective for reducing suicidal thoughts. So here's some of the steps that we took to designing this digital health intervention specifically for this age group. So digital health interventions are very expensive to design. So one of the reasons I was able to do this was because there was already an existing one. So when I was on internship at Rochester Institute of Technology, my clinical training coordinator, Caroline Easton, had taught us a integrated treatment for intimate partner violence and substance use disorders that's designed for adults. And it had an in-person treatment, and they were designing an adjunctive avatar guided piece of it. So this is the avatar that they were using for that integrated CBT for substance use disorders and intimate partner violence. So since at least like the building blocks of the platform already existed, it became much easier to adapt it for this age group. So first I created a mock-up of what the skills could look like, what the avatar could look like, using cognitive behavioral therapy for adolescents with alcohol use problems and mood disorders. That was basically developed by one of my K99 mentors, Tony Spirito, and my undergraduate research mentor, Christy Esposito Smithers. And then I also kind of looked at the MISTI trials, which is multi-systemic therapy for emerging adults. That was designed by Ashley Shado and Marianne Davis. Marianne Davis is here with an iSPARC. So kind of taking the different skills and seeing how they can apply to co-occurring alcohol use and suicidal thoughts. And then we did mixed methods to kind of hone down on those skills and add to things and then adapt the avatar. So first, I did a content analysis of all of the suicide prevention apps that exist within the App Store. So myself, a medical student and an undergrad, downloaded all 74 of those apps and rated them with a rating scale I'll show you in a few minutes. We consulted with our young adult advisory board, who's here within iSPARC. Those are young adults who have lived experience with mental health conditions, who gave us feedback on our research protocols and also on the avatar itself. Then we did individual interviews. I did individual interviews with 10 emergency department experts. So those are physicians, crisis intervention specialists, and nurses, really to see like how could this be offered within emergency departments as a key point of care where young adults can be seen. I consulted with clinical experts, so psychologists, therapists, social workers, to see if there should be any edits to the content of the intervention and how we deliver it. And then we did 35 focus groups with 35 young adults in surveys, really to see Again, should they be edits to the content, but also edits and changes to the avatar itself. And then throughout this process, I also had expert mentorship and collaboration with our interdisciplinary programming team, who's at Rochester Institute of Technology. So these are the different avatars that young adults specifically chose. So you can notice that at least the male ones, the young adults felt like sometimes they could be a little bit menacing, but they wanted them to look as realistic as possible. So these were the options that existed. Unfortunately, there's no bank of avatars that look like doctors or therapists or social workers. These are from video game platforms, and so it makes sense that the look and feel of them are maybe not necessarily what you would want for a therapist. And that's what young adults wanted. They wanted to design an avatar that either looks like an idealized version of themselves, like a therapist, or like another trusted adult or mentor. So we ended up, in part because there's not that much space in the avatar platform as well to add new things in, we ended up choosing the top, middle, and left avatars to add to the platform. So there's still male options for avatars in there. They're just the previous versions, since it seemed like people weren't necessarily sold on the bottom set of 3. The other things that young adults wanted were as much inclusivity as possible in terms of skin tone, hairstyles, body shape, and abilities. So they gave examples like having a cochlear implant or having a wheelchair user. There were multiple people that asked for an avatar that could wear a hijab, even if they didn't necessarily wear a hijab themselves. And it's because young adults have this value of having inclusivity. And there also just seemed to be a preference for female and non-binary appearing avatars. That could be people have a preference for female therapists, or I don't know, there could be something about young adults preferring a female or non-binary avatar. So how should the avatar interact with emerging adults? Like, what should it actually do? So right now, the avatar talks to a person, gives them psychoeducation, checks their understanding with a quiz, and does either an in vivo or an imaginal like coping skill exercise. Going to do some mindfulness exercises, or if they're like emotion-based coping strategies that they can imagine themselves doing. So the young adults also wanted the avatar to give more personalized praise and positive affirmations. They wanted to use myth busting about treatment options and to show the range of treatment options that are possible, as well as like non-office based interventions or support services like smart recovery or peer-based services. They wanted non-directive and encouragement. So never saying like you need to go to treatment, or if you notice these symptoms, you should go to treatment, but instead presenting different options. And similarly for coping skills or coping thoughts, presenting various options so that young adults can choose for themselves. And it's really respecting their autonomy. Their autonomy is very important for this age group. And then what skills should the avatar teach to emerging adults? Young adults and clinical and ED experts mentioned coping skills and thoughts like mindfulness and breathing exercises were helpful, and having new hobbies or activities to distract from suicidal thoughts, and then to replace drinking and to develop a sense of purpose. They also wanted help with social support and social issues. So navigating other people drinking or offering alcohol, gathering social support, and then problem solving around alcohol related situations. So if they have a goal to only have 3 drinks when they go out, what happens when they end up wanting more or people keep offering them more? They also really wanted harm reduction. So ideas for cutting down on drinking and cutting down on the risks associated with drinking. So for example, drinking and driving. Clinical and ED experts also consistently brought up trauma, that the app should encourage people to seek treatment to address the underlying trauma that is contributing to their drinking and suicidal thoughts. None of the young adults actually mentioned that. That could be because we had some people who are young adults in focus groups and some people who were in interviews. Even among all the interviewees, they didn't mention trauma. So we use traumatic stress and trauma triggers as examples of triggers for drinking or suicidal thoughts, but we didn't necessarily make it an overarching aspect of the intervention. And we don't have it in the resources section as like go to treatment for your trauma, because that wasn't something that the young adults brought up. So we kind of incorporated the feedback from the clinicians and ED experts in other ways. So this is what the platform actually looks like. So you can see the avatars in the middle. They read the text on the side, so they provide the psychoeducation for people. Then they practice that skill in vivo or with kind of an imaginal exercise, and they provide encouragement to the person throughout. They also ask them questions with slider scales or yes/no questions or like multiple choice questions to keep the person engaged. Then the young adult can also earn badges or awards for doing some of the different modules. So the modules are listed on the topic section, and there's 10 of them. I'll show you on the next slide. There's also a couple of goal statements that are repeated each session. And then the games are actually just being piloted as part of this platform, but young adults can use them to distract from cravings or suicidal thoughts if they'd like to. So here are the names of all of the different topic areas. So the first one, there's an introduction that is cut off, but there's skills around associations between drinking and suicidal thoughts, safety planning support, benefits of cutting down on drinking, triggers and coping skills, and then some harm reduction strategies. Getting out there is another name for behavioral activation. So those are the hobbies and activities that young adults wanted to replace drinking and develop a sense of purpose. Managing my feelings, which are emotion-focused coping strategies, and then finding support has essentially encouragement and a lot of different treatment options from outpatient therapy all the way up to inpatient treatment. So where are we in testing this intervention? So we've done the development stage. There's still a couple of line edits that are being made to the intervention right now. And then we're testing the usability in our emergency department here at UMass Chan. Usability is really important for digital health interventions. It's if people don't even know where to click on something, if there are glitches or bugs, or it just doesn't make sense, how things are laid out, then it's really hard to actually test if people are using it. We also have some pretty intensive research protocols. So there's a baseline assessment and then a follow-ups at 4, 8, and 12 weeks after discharge, and then 28 days of daily diaries and brief surveys where people complete brief surveys up to 4 times a day randomly. We don't know if that will be too burdensome for this age group. We also don't know if we really need 28 days. If people have some indicators of drinking and suicidal thoughts after 14 days, we don't necessarily need the lengthier time period. And then once we refine the protocol and refine the intervention, we'll test for efficacy in a pilot feasibility randomized controlled trial where we're comparing standard emergency department care and the Avatar platform to standard emergency department care and a suicide prevention app that's available within the App Store. Okay, so how can we all as clinicians then evaluate digital mental health tools? So for example, I mentioned there's 74 suicide prevention apps. How would we see which ones are useful? So I've been a part of 3 different content analyses for apps for substance use problems or suicide prevention. Essentially, the big picture is for smoking cessation and alcohol, tailoring, so have any types of tracking or ways to tailor the app content was associated with people liking it, so their star ratings and how popular they were, so how many times they were downloaded. That wasn't necessarily true for the suicide prevention apps though. So 22% of the apps in the App Store right now have a personalized safety plan where someone could input things into their suicide prevention safety plan. They can get contacted or they can contact a support person, they can contact an organization to help them, like the National Suicide Hotline 988. And unfortunately, I'm not necessarily sure why, but my hunch is that if there's any type of glitches or user difficulty with a safety plan, people are going to end up rating it more negatively. And there's also just so many different parts of a safety plan. There just might be more opportunities for glitches or difficulties to arise. Okay, so I'm going to show you all the rating scale that we used in the suicide prevention app content analysis. I would think that these are excellent tools for students, so medical students or other graduate students who have the ability to really review extensively these apps that are available. These are all the different types of questions that are in the mobile application rating scale. And then there are anchors for 5 different options. So each of these also has 5 different options with them with examples of what it would look like. So is the app entertaining? Is it interesting? Can you customize anything? Is it interactive? And then is it seem to be built on purpose for your target group? Then there are functionality questions. So how accurate or fast does the app features work? Is it easy to use? Is it easy to navigate? So knowing like how to get to different areas of the app. And then are the gestural design features, meaning like if you need to like zoom in on something, if you have to click on something or move from one area to another, does that make sense? So again, these things like the functionality are really important for digital health interventions. It's not something you would have to worry about for an in-person one, but these are important if people are using them on their own. And then for aesthetics, does the layout make sense? Like, are there options throughout the top or the side that make sense to people? Or it's like the contact information, a place where you can find it? Are there graphics that are high resolution? Is it visually appealing? Does it look good, basically? And then in terms of information quality, is the app description in the App Store accurate? Does it contain what's described in the App Store? Does the app seem to have a specific goal in mind, like it'll help your patients learn different coping skills? Is the quality of information good? So is the app content correct? Is it well written? And is the quantity of information okay? So enough information that'll be helpful to people, but comprehensive, but also in a concise way. So not too much information like an ebook, but enough to help people. And is the visual explanation of concepts, like if there are any videos or graphs, do those make sense? And then is the app from a credible source, like a government organization or an organization that is focused on mental health, for example? And then is there any evidence base for it? So many apps haven't been through randomized control trials. Of the 74 suicide prevention apps, only 2 of them had been tested for feasibility in small randomized control trials. But is the tools that are being presented from an evidence-based platform. So if it's a cognitive behavioral therapy app, for example, even if it hasn't been tested itself, CBT has shown efficacy. There's also a subjective rating portion of the MARS. We wouldn't recommend this for researchers or clinicians to complete. This is really for users to say if it actually helped them or worked. And this is also where we get our star ratings. So we found that the subjective ratings of patients or users, so the star ratings that are available in the App Store, were related to our researcher rating scale. So essentially, if you use the MARS, you can be pretty confident that your patients are going to like it and use it too. These were the top 10 suicide prevention apps found in our content analysis using the mobile application rating scale. So just some things to note, like why we think that these 10 kind of came to the forefront. We think it's because these were certainly by credible sources. So the PTSD Coach app is made by the United States Veterans Association. The Canadian Association of Mental Health did number 9, the Hope by CAMH. And then the Durham Mental Health Services created number 5, so DMHS Suicide Prevention and Crisis Access Linkage Line. They also, a few of them have an evidence base to them, like DBT Coach is based on dialectical behavioral therapy and really maps onto that intervention. And some of the other ones, it's really that they worked well. They had features that were helpful for people. They had coping skills within them that can replace somebody having to use or practice coping skills on their own. So again, our rating scales with the mobile application rating scale really mapped onto user satisfaction ratings. So they were correlated. And then all of these in the top 10 also had a rating of 4 or more out of 5 on the App Store, with one exception that was pretty close. So essentially, if you have your students rate some mobile applications, it's likely that patients will like them as well. There's also a screener for app like user ratings with the American Psychiatric Association. So these are some questions that you would go through to determine if you want to do the more extensive rating scale. So APA has, like, can you have an app version and a computer version? Has it been updated in the last 180 days? Is there a privacy policy? Does the app collect or use information? So especially if the app can send information to you as a provider, does it do that in a secure way? Or does it sell any of that information to a third party? Is there evidence of specific benefit from either an academic institution, end user feedback like testimonials or research studies? Does it have a foundation relevant to your clinical use? So if you are a CBT therapist, does it use cognitive behavioral therapy? Does the app seem easy to use? So again, you'd have to download it and see if you can kind of click through things and it makes sense. And can the app data be easily shared in a way that's consistent with the purpose of the app? Does the app do what it's intended to do? So these are some additional recommendations that I would have just based on our use of the mobile application rating scale and the APA guidelines. So first, can you contact the developers from within the app? That makes people feel more comfortable that if there's glitches or changes that need to happen, they can tell that to the developers. Is it made by a reputable source? So the Veterans Association, the Substance Use and Mental Health Services Administration, any other government organizations. It seems like Canada, Australia, and England all have apps that are available here within the United States by their government organizations that we can also use. Does the app share data with third parties? Or is it giving secure data? Can you see any negative feedback within the App Store? Can you immediately download it and see that other people are saying, like, this is broken, like, don't use this? Or does it have a rating scale? I would say if it has a star rating of 3 or less, I would be a bit wary about it. Is the app description accurate? Does it seem to promise too much? Does the app have a feature or two that could replace a paper and pencil task for you? And then does it offer something to your patients that would help them practice some type of skill that you would do in your office too? And then do you as a clinician like it? Because again, we saw with the mobile application rating scale, if we like it, if we're rating it positively, then it's likely that patients will as well. So I'm going to go through an example of a suicide prevention app that's actually newer than our content analysis that we did. It's called Safety Plan, and it's by the U.S. Department of Veterans Affairs. So first, you can see that you can contact the developers. So if you download the app, there's a way to, like, make a complaint basically, or like contact people. It is made by a reputable source, so it's made by our Veterans Association here in the U.S. The additional questions that I was giving as recommendations are, is the app description accurate, or does it seem to promise unrealistic things? It really tells kind of exactly what it does. It lets you fill out the 6th part of a safety plan. You can share that safety plan with other people, includes audio and interactive tools, and then it has mood tracking and gives you access to crisis support. So it calls 980 directly from within the app. So it's not saying like you are going to feel happier from using the app or develop a sense of purpose in your life just from using this app. It really is describing what it does. The app privacy settings here, the data isn't linked to you. It does say it collects identifiers. I think it's collecting, like, if the person is male or female, it might collect their racial demographic information. That could eventually be used, I think, to link to somebody's identity, but it's not sharing people's, like, email address or their name with anyone else. I'm also guessing that this data is collected so the VA can say that the app is working well. But this is not necessarily the most strict of all of the privacy policies. And can you see negative feedback in the App Store? So basically there's a 5 out of 5 rating with 13 ratings, and people don't have to put qualitative or written information, but all the written information is also positive. The first one is cut off here, but it's someone who works at a mobile crisis, and they say that they're going to recommend using the app. It also says that it can be used for veterans and civilians. So again, that might be something that your patients might not know, is that our apps by the VA are not necessarily veteran specific. Anyone can use them. And then these are all of screenshots of all of the different features of the app. So there are certainly features or two that could replace paper and pencil tasks. So if people can put in their safety plan directly into the app, that replaces a paper safety plan. It means that it'll be there. Even if they lose their phone, they can re-download the app and it will be there. And it has all 6, parts of a safety plan that are recommended. There's also different information that somebody could learn about why they would want to safety plan, what happens if they call a crisis line, how to ask for help. So there's certainly information as well. Then can the user practice coping skills or a coping skill activity within the app? So that's over here. So there's all these different tools that people can use. So that way they're not having to do those coping skills on their own. They really have the support and kind of instructions for how to do it. So then do you as a clinician like it? So I would recommend just taking a look at it and seeing if it looks appealing, if some of the like ambient sounds or the coping skills exercises, if like the voice that does them is appealing, if you like it, then it's likely that your patients will too. All right, so just to go back through our learning objectives, we saw that emerging adults have the highest rates of behavioral health problems and unfortunately the lowest rates of traditional behavioral health treatments. So digital health tools could be something that bridges that gap and offers them support. I showed you an example of user-centered design and how we integrated feedback from end users, so emerging adults who are seen in the emergency department for alcohol use problems or suicide risk, as well as clinicians and emergency department experts, and really how we're using that iterative approach to make sure our platform is usable and that it's helpful for people. And now you all have a couple of tools to understand how to select digital health tools that are freely available within the App Store. I just want to say thank you to iSPARC, to the Cape Suicide Prevention Center, to UMass Psychiatry. Follow us on LinkedIn and Twitter. As Dr. Rothschild noticed, I'm the dissemination and community engagement lead now for the Cape Center. So if people follow us on social media, I'll especially appreciate it. And we share information about up and coming information about suicide prevention. I'd also just like to thank my K99 mentors, Kristen Zajac, Howard Tennant, Tony Spirito, and Caroline Easton, and the participants who participated in our original research study, our Young Adult Advisory Board, and then the Cape Center. And any questions?
Hi, thank you for this wonderful talk. I'm a third-year psychiatry resident. I can easily see ways that I can implement this in my own practice. I wonder, it sounded like the emergency medicine specialists you guys have interviewed had suggested trauma as another important topic.
Mm-hmm.
And it sounds like, young adults or emerging adults might not be likely to report that as something that they think is as important as it might be.
Mm.
But I feel like from working with my own patients, we end up uncovering, traumatic experiences from their past that have otherwise been insidious, but nonetheless are having big impacts on their quality of life. So I do wonder if there might still be some value in including some trauma education, even though the emerging adults might not be conscious of either their past trauma or how trauma is affecting them.
Absolutely. So the thing that comes to mind is that it's possible that young adults are just not aware of the ways that their traumatic experiences may be driving alcohol use or suicidal thoughts. At least for this platform, it just seemed like young adults were saying there are so many barriers, and the moment something negative happens within an app, they're just going to not use it anymore. So we do have things around that traumas can be triggers for alcohol use and for suicidal thoughts, that traumatic memories are actually assessed in our daily diaries too. So the surveys that happen each day for 28 days after discharge. So we'll also be able to uncover how often these young adults are having memories of trauma. I just wonder if early on, if we follow the young adults' advice and say that like anything that could potentially turn them off, we tread lightly well. It's not that it's not included though.
Hi. So I noticed on your slide where you were talking about the reasons why young people didn't access treatment. I didn't see they tried to access, but the wait list was too long, or they tried to access and there wasn't anything available. And I was wondering if you asked them that, or if they just didn't think that that was a problem, because I could see this being a tool for those situations when there are long wait lists and access issues.
Yeah, that's a great point. And that's actually part of why we are implementing within the emergency department, is because we think that if somebody gets discharged from the emergency department to the community, they likely have a long wait list to a provider. Or they could also have a long wait list even after coming out of inpatient treatment as well. But the questions that you're mentioning are part of the national survey. So not necessarily ones that we had asked young adults. But I just wonder if maybe those weren't asked if somebody tried and then didn't get into it. It's also, these are, I'm just gonna go back to it. I don't think that these were extensive. There might have been another couple of items that I didn't present here. There's also, I think, a qualitative response. So it's possible that if somebody went around and coded those qualitative responses, that could be in there. But I'm sure, or even if somebody didn't necessarily approach a clinic and hear about a long wait list, they might have, looked up things about treatment, but then not really followed through with it. So they're like maybe treatment curious. Absolutely. So for sure, I think the digital health intervention could be helpful for them because it tells them more about what an intake process looks like, what are the various treatment options that could be helpful for them.
We have some questions online. One is, given the high prevalence of borderline personality disorder among patients who access emergency rooms with substance use disorder and suicidality, have you considered including any educational content in your app specifically targeting the subpopulation of borderline personality disorders, SUD, and suicidality?
That's a really good point. We haven't considered making anything like diagnostic specific, in part because we wanted this to be offered to anyone basically with suicide risk who has some level of drinking. And again, because suicidal thoughts they cut across all diagnostic categories and occur among people who don't necessarily have a diagnosed mental health condition. But to the person who's asking this question's point, there could be some things that we would need to adapt for how we present this to somebody with borderline personality disorder. There's also been some discussion, like, what if somebody doesn't want the avatar? They want the same information, but they don't necessarily want the avatar talking at them. Can we just delete them? Is there an option for that? I think the question was coming around like maybe people with schizophrenia who could be like off put by like the kind of facial information, or maybe somebody with autism might not want that as well. Or maybe young adults who are just really used to very immersive, realistic avatars don't like ours. So that's, I think, an option too. But we haven't necessarily considered adapting for BPD at this point.
One of your slides mentioned that I think maybe all but 2 of the apps cost money. So I was wondering whether that was identified as a barrier, apps that cost money, and 2, as an expert, what do you think about pricing of these types of apps?
So one of them that comes to mind is the DBT app does have features that cost money. So essentially you can download the app and you get a few features, and then to get every feature and then to, I think, communicate like your progress with your therapist, you have to pay a monthly fee. And it is quite high. I think it's something like $49.99 a month. It's pretty high. It's almost like having a personal electronic health record almost. There are a lot of cool like features within it. But I would say that if if something needs to be paid for and in order to be offered, then it seems like the app kind of needs to pay for itself. So for example, right now the NIH is paying for this to be designed, but in terms of implementation, we might need to offer something like either having a health system pay for this in order to offer it to their patients, or is there some way that you could get some of the features for free and then like having an additional price for some of the more advanced features?
I mean, if the NIH is paying for it, it should be free once you're done, right?
I mean, I would think so.
So unless somebody patented it, but one of your fans out there is promoting a podcast that you did on this on interventions with avatars for young adults. So those of you on Zoom can see the link. You have another question. Oh, the same person also says it's on YouTube.
So the iSPARC Transitions to Adulthood Center has a podcast series. They're great. I was featured in one of them. It is on YouTube, but it's also on Spotify if you search for it.
All right. Well, thank you very much, Lourah.